We have two presenters today from presenting from Sinai, and first up is Evelyn Cheung, and I'll hand it over the controls to you, Evelyn.
Hi everyone, so I'm doing a short presentation today on randomized delayed start trial of levodopa in Parkinson's disease. It's my last journal club. I have no conflict of interest. So the goal of the talk is to review this article, which is basically look at whether levodopa has any disease-modifying effect in Parkinson's disease. The reason why they did this trial in 2004, which is a long time ago, there was a study, which is also published in New England Journal, that showed that after 40 weeks, when they grouped two separate groups of patients, one group received levodopa and the other did not receive levodopa. And after taking it for 40 weeks, and then they reanalyzed the patients 2 weeks after stopping all medications, the degree of deterioration of those who were on levodopa was significantly less than those who were on levodopa. So there were two interpretations. One is that there was a disease-modifying effect, or one is that there is a prolonged effect of levodopa. But then they also did neuroimaging studies that show that people who were on levodopa actually had more accelerated loss in the dopamine nerve terminals, which was conflicting with what they were seeing in the original study. So eventually they wanted to do another study to look at whether levodopa had any disease-modifying effect, because it will change the way when we start prescribing levodopa. So the PICO for this is so they look at anyone who's over the age of 30 years old, but with insufficient disability where they needed to be treated with the anti-Parkinson medication. The diagnosis have to be made within the past 2 years by a neurologist. The intervention is levodopa, the lowest dose, 3 times a day, and the control is those who are not taking, but they will be taking a placebo 3 times a day. But then after 40 weeks, they will be taking the medication. So the outcome is the UPDRS score, but then they also look at cognition, the MMSE, and then their function, and which is the BDI, and then the PDQ-39 is the mood. So it took place at the Netherlands between 2001 and 2006. So there were 2 phases of this study. So in phase 1, the first 40 weeks, their intervention group received levodopa 3 times a day, and the control group received placebo 3 times a day. And then in phase 2, after 40 weeks, everyone takes levodopa. So in this way, they can look at, they will be comparing the data and see if there's any disease-modifying effects. They excluded anyone who has previously been taking any type of anti-Parkinson medication, and also if their main symptom is tremor, which caused disability, they would exclude them, which I'm not sure why. And no one who had dementia, and after being evaluated by a neurologist, anyone who had any atypical or secondary Parkinsonism will be excluded.
L-dopa is particularly ineffective against tremor, that's why.
Yes. And the way they randomize it is a stratified randomization, where there were 3 variables they looked at, which is whether it's academic versus community, the age, and the duration of symptoms, because they all have the way levodopa could impact on age versus symptoms has a difference. So I know a lot of people have talked about what this stratified randomization. So essentially, you group them into the respective group. Like in this case, for example, age is that the lighter smiley face is like less than 65, and the darker smiley face is over 65. And after you separated them, you re-randomize them. But this case, there were 8 groups because there were 3 different types of variables that they stratified. And this is the way the study was. They recruited 766 patients initially, and then some didn't meet inclusion criteria, and then 445 eventually underwent randomization and equally divided between the 2 groups, which is the early start and the delayed start. Most of them completed the entire study, which has over 93% of completion rate. And just to make a note is that in phase 1, because they have multiple assessment at like week 4, week 22, week 40, if at any point they were deemed to be having too much disability and not and they should be on levodopa, they would be switched to open label. And if they were not on levodopa, they would start taking levodopa. And if they were already on levodopa, they would just keep taking the same dose of levodopa. So in terms of what statistical test they use, the primary change, like with regard to the UPDRS score, they use the t-test to compare the score at week 80 and also at week 40. And then the other test, the secondary outcome they look at was the rate of change between week 4 to 40 and week 44 to 80 between the two groups. Their hypothesis was that if the disease progressed more during phase 1, which is week 4 to 40, in the delayed start group, while in the phase 2, which is from week 44 to 80, and they decided to use a non-inferiority test in phase 2. If they cannot demonstrate non-inferiority of phase 1, which is the early start group, to the delayed start group, they deem that it means that there is no disease modifying effect, which I'm not quite sure why they decide to say if it's not inferior. So comparing the two groups, they're a little bit younger than people that we usually see. They're in the 65, 64 range. More males, as we know, is more common in males for Parkinson's disease. 30% recruited from academic hospital. I only included the part 3 of UPDRS score because that's the motor part. And 18 is very, very mild, and most people are usually not on any medication. Their total score is 28, which is also extremely mild. And then the ALD score is the disability, which a lower score means a higher disability, so really not disabled. BDI is the depression score, and again, a higher score indicates more severe symptoms, more severe depressive symptoms. So they're not depressed in this group. So this is the results. So with regard to, in general, the only part that is significant, so from the UPDRS score, the change from baseline to week 80, it is not significant at across 0. So they both, in both groups, they all ended up with the same score. And then with regard to the change from baseline to week 40, which means in the early start group, they were taking levodopa, and the delayed start group, they were not taking levodopa, we showed that there was a significant change. So the delayed start group became worse. And then, so that's the primary outcome. And then in the last two rows is the secondary outcome. So they look at the rate of change between week 4 to 40. So they again show that there is a significance with regard to that, because in the early start group, it was non-significant because it's crossed 0. And then in the last part, which was looking at the rate of change between week 44 and 80, in that case, both groups were taking levodopa. This is actually not significant because the non-inferior margin, they set it as 0.07, so they actually crossed the margin. So in this case, they actually, it's the same as their hypothesis, where in phase 1, when only one group was taking levodopa, the group that was not taking levodopa progressed quickly. But then when they both took levodopa, group 1, which is the early start group, was not non-inferior compared to the delayed start group. So this is the graph where they show how their UPDRS score progressed. So again, higher score means that it's more severe, and lower score means that it is less severe. They had a little bit of concern why there was a gap at week 44, and they hypothesized that it's because the effect of levodopa might not have taken place after 4 weeks of taking it, and that's why there was a little bit of discrepancy with regard to rate of change at that point. And with regard to their other outcomes that they look at, with disability, cognition, depression, and quality of life, it was completely non-significant whether you started 40 weeks before or 40 weeks after. And then there was adverse side effects where in the levodopa group, there was significantly more nausea, which is expected. To critically appraise the paper, it is a randomized controlled trial, and its intention to treat the group of balance. The only thing we're not sure is if there's concealment of allocation, and follow-up was up to 93%. Even though the drugs were subsidized, but they were there was no role in them in the study itself. In terms of the strength, there were a couple of other studies in the past that try to look at this property, even though most of us feel that it was not disease modifying. And this part does have a longer phase 1 trial of 40 weeks, which allow for any disease modifying effect to take place. With regard to the limitations, I mentioned that in phase 1, if they became significantly debilitated, they would be turned into open label trial where they would just receive the levodopa. So up to 39% of patients in the delayed start group actually started taking medication early. So they actually did another analysis where they looked at per protocol analyses, and they did not find difference in their results. So the conclusion is that I'm not going to change my practice because as what we kind of most people feel is that levodopa, carbidopa has no disease modifying effect that should only be started for symptomatic treatment. Thank you.
Just FYI. Okay, that's great, Katie. We see your slides now.
Perfect. Okay. So as I was saying, I'm doing the long presentation, and I chose to do the sprint mind trial, so I'll get right into it. I can change it. Okay. So I have no disclosures. My objectives are fairly straightforward. I'm going to look at some past literature on blood pressure and cognition, review the current study, do some critical appraisal, and then there'll be time, hopefully, for questions and comments. So hypertension is a good kind of focus for an elderly population. 3/4 of our population will have the diagnosis. There are many studies that have looked at this as a modifiable risk factor for dementia. And so now there's this interesting question of if hypertension and cognitive change have some linkages. So there are studies that look at cognitive cognitive decline in blood pressure, and some studies, specifically randomized control trials of SBP reduction, have shown some cognitive improvements. These are just a couple of the studies that have been done in the past. The ones that are bolded are the ones that have been done against a placebo group. There have been other studies that have just looked at differences between different antihypertensives. One of those studies is the Progress trial. And this trial was done in 2003, and the study aimed to determine whether blood pressure lowering would reduce the risk of dementia and cognitive decline amongst individuals with cardiovascular disease. It was a randomized, double-blinded, placebo-controlled trial conducted among 6,100 people with prior stroke or TIA. Patients were assigned to either active treatment, which was perindopril plus or minus indapamide, if there was no contraindications, or a matched placebo. And the primary outcome for the analysis was dementia, and that was using the DSM-4 criteria, or an outcome of cognitive decline, which was a decline of 3 or more points on their MMSE score. To orient you to this slide, this is their two forest plots that were included in their trial. The top plot looks at the effects on risk of dementia. The bottom looks at the effects of treatment on the risk of cognitive decline. During a mean follow-up of 3.9 years, dementia was documented in 6.3% of randomized versus 7.1% of randomized placebo group patients. Or sorry, the first number was active, second number was placebo. So they didn't actually see any statistical significance, nor did they see any statistical significance with just cognitive decline. What they did see was that their composite outcome of dementia with recurrent stroke and cognitive decline with recurrent stroke had a reduction of 34% between the active active treatment and placebo groups. What the authors concluded, was that active treatment of blood pressure was associated with reduced risk of dementia and cognitive decline when it was associated with recurrent stroke. So that did support the recommendation of reduction in blood pressure. Now, some randomized control trials that looked at SBP reduction and cognitive assessment that did not show improvement are listed here. And again, the bolded ones were done with placebo groups, and they were also done over longer periods of time. One of those trials was the HIVET-COG study, and the HIVET-COG was a study published in 2008. And the aim of the HIVET-COG sub-study, which was done within the placebo-controlled double-blinded HIVET trial, was to assess whether treatment of hypertension in patients aged 80 or over would reduce incidence of dementia, vascular dementia, or Alzheimer's disease. Patients with hypertension, so a systolic of 160 to 200 and a diastolic over 110, who were aged 80 or older, were enrolled. Patients were randomly assigned to receive 1.5 milligrams of slow release indapamide with the option of 2 to 4 milligrams of perindopril or placebo. The target blood pressure was 150 systolic, diastolic was 80, and there was no clinical diagnosis of dementia in the participants at baseline, and cognitive function was assessed at baseline and then annually with an MMSE. The causes or possible cases of incident dementia were defined by expert review using standard diagnostic criteria, and these were from patients polled who had an MMSE score of less than 24 or a drop of 3 points in a year. The trial was stopped in 2007 at the second interim analysis after treatment resulted in a reduction of stroke and mortality. So perhaps the true impact of the cognitive portion of the study may have been attenuated. This is their figure from the HIVET-COG article, figure 2. Oh, my bad. This is the study, or figure 2 from the HIVET-COG article. It shows the unadjusted survival analysis for incident dementia. I didn't mention, but their table 1 with their baseline characteristics were very, very identical. They were average 83 years, majority women, similar blood pressure, similar amounts of stroke, cardiovascular disease, baseline MMSE scores. Ultimately, there was no significant difference between treatment and placebo groups for the diagnosis of any dementia. The main trial was stopped early, as I mentioned, because of substantial reduction in total mortality and stroke, however. The mean decrease in blood pressure at 2 years was 14.6% on placebo versus 29.6% on treatment, which was statistically significant. The mean change in MMSE score was 1.1 points versus 0.7 points, which was not statistically significant. And all patients with serial MMSE scores were included in the analysis, and any records that showed cognitive decline were assessed by the committee, irrespective of death and other events. The authors stated that there could have been more of an effect if there was longer duration of follow-up, as the study was stopped earlier than planned. They also did lots of statistical analysis, looking at various factors, including education, region where recruitment occurred, age, and none of this changed their results. So the other question is, could there be harm? And there is some observational studies that have identified an association between low blood pressure and risk of further cognitive impairment. And one of those studies was done by Masello et al. And published in JAMA in 2015. And it was a cohort study looking at the effects of low blood pressure in cognitively impaired patients treated with antihypertensive drugs. They wanted to assess whether office blood pressure, ambulatory blood pressure, or the use of antihypertensive drugs predicted a progression of cognitive decline in patients with overt dementia and MCI. As mentioned, it was a cohort study done between 2009 and 2012 with only a 9-month follow-up of patients in 2 outpatient memory clinics. The main outcomes they were looking for was cognitive decline, defined as an MMSE score change between baseline and follow-up. What they found was that patients in the lower tertile of daytime systolic blood pressure, so less than 128, showed statistically greater MMSE score change. And by that, I mean reduction by 2.8 points on average compared to patients in the intermediate or highest tertiles. The association was significant in dementia and MCI subgroups only among patients treated with antihypertensive drugs. And it was in a multivariate model, including age, baseline MMSE scores, vascular comorbidities, low daytime SBP, and antihypertensive drugs were independently associated with greater cognitive decline in both subgroups. So the authors concluded that low daytime SBP was independently associated with greater progression of cognitive decline in older patients with dementia and MCI in those treated with antihypertensive drugs. This study certainly had limits. It was a very small sample size, and obviously it was observational, so you cannot determine causality. And finally, the follow-up was very short. It was only 9 months, and sometimes we don't even do MMSE scores in 9-month intervals because the change might be so slight. So something just to consider. So now I will transition to the paper of choice today, the Sprint Mind trial. It was recently published in January, and as we know, it was published by the Sprint group as a pre-planned offshoot of their original article published in the New England in 2015. The original Sprint trial was designed to test the effect of more intensive BP control of cardiovascular outcomes in persons without diabetes or pre-existing stroke, which was their primary endpoint. But this article is solely describing the effects of intensive BP control on the rates of probable dementia and MCI compared with standard treatment goals of less than 140. So in their method, they conducted a multi-center randomized clinical trial that compared the two strategies of managing systolic blood pressure in older adults with hypertension who are at increased risk of cardiovascular disease. Patients were aged 50 or older and had an SBP between 130 and 180 millimeters of mercury at their screening visit. They were considered to have increased cardiovascular risk if they had clinical or subclinical cardiovascular disease, CKD, or Framingham score of 15 or greater, or if they were just 75 or older. Their exclusion looks like a reason for referral to a geriatrician. Individuals residing in a nursing home, persons with diagnosis of dementia based on clinical or medical record review, those treated with medications primarily used for dementia therapy, assuming that as a proxy that they had a diagnosis that just wasn't documented, and persons with prevalent dementia or history of stroke. So they were randomized by their specific coordination center in a 1-to-1 ratio to either an SBP goal of less than 120, which was the intensive treatment group, or an SBP of less than 140, which was their standard treatment group. The randomization was stratified by clinic site, and all major classes of antihypertensive agents were included in their formulary and provided at no cost to participants. The protocol encouraged but didn't mandate specific use of certain antihypertensives for certain issues. So thiazide diuretics as a first line, loop diuretics for patients with CKD, and beta blockers for those with CAD. Enrollment began in November 2010 and ended in March of 2013. Their cognitive assessments were done in kind of 3 stages. So first, they did in-person cognitive screening at baseline and then at their follow-up marks. In-person cognitive screening assessments were administered to all participants at a baseline and then during follow-up by a centrally trained and certified examiner at each local site. And their base cognitive testing included a MoCA, and then they took the forms, logical memory forms 1 and 2 from the Wechsler memory scale. They also took the digit symbol coding test from the Wechsler adult intelligence scale. I tried to actually obtain these scales online, but they're behind a paywall and it was quite challenging. So I'm not super familiar with them, but maybe some of you are. And so in certain people listed on the slide, they did do functional activity questionnaires. So when you hit kind of a MoCA score of 19 or below if you were white with no high school education versus 21 or below if you had high school education, they would then do a functional activities questionnaire. If you had a decrease of 5 or more on a MoCA from a previous assessment, no matter the score, they would also do a functional assessment. So this is actually part of their supplementary material from the Sprint Mind trial. It's nice, I liked how they organized how and when they did certain cognitive testing. So they did more than what that previous slide mentioned for certain situations. So if a participant scored higher than 0 on the functional activities questionnaire, meaning they needed assistance for any activity, or scored 1 or lower on the delayed recall portion of the MOCA, they did further testing on attention, concentration, verbal, nonverbal memory, language, and executive function. And that's shown in table 1 there. They also had a telephone battery that was administered for patients who couldn't be there in person for follow-up. And the patients or participants receiving the telephone battery, they had a functional activities questionnaire administered if they scored below a preset cut point of 31 points for this modified telephone interview package. If the patient had died or was unable to communicate by telephone, a dementia questionnaire was administered to a pre-specified contact that they had. So in addition to cognitive test scores and proxy functional status reports, all participants were administered a standard measure for depressive symptoms, perceived health status, quality of life, reported current medications, medical problems, and current health habits, including smoking, alcohol use, physical activity. They also documented any hospitalizations for any of the participants. All the data they collected was used by an expert adjudication panel to determine cognitive status. The panel included a neurologist, neuropsychologist, geriatricians, and geropsychologists. The adjudicators were masked to treatment assignment, and participants were classified as in one of 3 categories, either no cognitive impairment, MCI, or probable dementia. They also had a 4th cannot classify category. Each case was reviewed by only 2 of the adjudicators in that group using standard diagnostic criteria for probable dementia and MCI. If there was disagreement among those 2, the full panel discussed it and majority won. There was no subclassification of probable dementia, but they did subclassify MCI using Winblad et al. Criteria and subclassified it into 4 domains as seen on the slide. And again, this is from their supplementary material: amnestic versus non-amnestic, and then multi versus single domain. The trial was stopped in August of 2015, which was earlier than they had anticipated because their cardiovascular results after analysis of the primary outcome showed that the monitoring boundaries were exceeded at 2 consecutive time points. So that initiated the process of ending the blood pressure intervention. This was occurring as many of the planned year 4 cognitive assessments were being done, so many had not yet been completed as of that date. So were completed kind of around this study closeout period. While the trial was still providing medications at no cost. However, after the trial was stopped and during the closeout visits, BP management decisions were returned to the participant's primary care physician, and medications were no longer provided free of trial. The final extended follow-up, which was done while they were at their primary care physician with their medications not given for free, was done between October 2017 and July 2018. So that's that red box that you see. That's when they had the extended follow-up, and those 4-year visits occurred during their closeout period. Okay. So the primary cognitive outcome was occurrence of probable dementia. Their secondary cognitive outcomes included occurrence of MCI and a composite outcome of occurrence of probable dementia or MCI. Mild cognitive impairment was defined as 2 or more consecutive occurrences of adjudicated MCI. So they couldn't have just been adjudicated once, they had to have had a second determination of MCI. They also did some post hoc outcomes looking at first occurrence of an adjudicated MCI to see if there was anything there. They also had a number of pre-specified subgroups that they looked at as well, and you can read those. So the primary hypothesis for the cognitive assessments was that the incidence of all-cause probable dementia would be lower for participants assigned to an intensive treatment group compared with counterparts assigned to a standard treatment over an average of 60 months of follow-up. The time to occurrence of probable dementia, MCI, or the composite outcome was compared between the 2 treatment groups using Cox proportional hazard regression with the baseline hazard function stratified by clinical site. I do want to note that in their statistical analysis section, they did mention that no adjustment of the significance threshold for secondary or other endpoints was made, and because of their potential for type 1 error, false positives, the finding of these analyses should be considered exploratory. Oopsies. Okay. So this is their figure 1 showing a randomization. They essentially had pretty good participant completion rates all the way through up until their closeout, up to 90% for both groups. Their completion rate in the extended follow-up group, which was the time after the trial when they were returned to their family physicians, actually dropped to about 60% and 59% respectively. So they had a bit of a decreased rate after the trial was over. So
Can I just ask one question? For the patients referred, were they already diagnosed previously as being hypertensive?
Yes, they.
Okay, so they only got the referral for, okay.
Yeah, they're. I think I mentioned it before. They had they were between can't remember the original 130, 170 systolic at screening visit. All right. So their table 1's very long, so I extracted some of the important characteristics to show you, but overall, their two groups were very similar. What I didn't show here is race, which was similar across white, black, Hispanic, and other. Diastolic blood pressures were very similar amongst the two groups, as was incidence of orthostatic hypotension. Other things like cardiovascular disease, average EGFR, EGFRs of less than 60 were almost identical between the two groups, so they were quite similar. Up until the decision to stop the trial intervention, there was sustained between group differences in the systolic blood pressures. The mean systolic was 121.6 in the intensive treatment group and 134.8 in the standard treatment group, resulting in a mean between group difference of 13.3 millimeters of mercury. During the study closeout period, which is the middle of the graph, the between group difference was reduced to about 10.5 millimeters of mercury, largely due to an increase in the systolic of the intensive treatment group to 125 on average following conclusion of the trial. And then in the extended follow-up group, which is kind of the last box, the between group difference further reduced to 6.4 millimeters of mercury, and again attributed to a further increase in the systolic blood pressure in the intensive group, up to 129.2. Now, their results. So in the intensive treatment group, 149 participants were adjudicated with probable dementia compared with 176 in the standard treatment group. In their supplementary material, they also excluded this extended follow-up group to see if that made a difference, but no matter what, there was no statistical significance there that they could find. In the MCI group, there were 287 participants in intensive versus 353 in the standard group that were adjudicated MCI, which did translate into statistically significant difference between the groups. I included their graphical representation of probable dementia by treatment group also. The shaded regions indicate the 95% confidence interval, and as you can see, there is a nice overlap between the two. This is their, so this is another supplementary table that they provided, and it shows those that were actually excluded versus those included in the analysis for probable dementia. Those that were excluded because they couldn't get any cognitive testing done after the initial baseline assessment, so no follow-up cognitive testing. What you will notice is that patients in this group generally were more likely to be female, more likely to be Black, had lower cognitive test scores at baseline, higher levels of frailty, higher levels of depressive symptoms, generally frailer, probably more concerning patients that you would wonder would progress to dementia, which they were actually removed, and there was close to 1,000 of them. So it was a pretty big group that had to be removed. So it's a pretty vulnerable subset not to be included in the final measurements. Just quickly looking at their subgroups, this is their forest plot provided, and there was no significant differences or interactions between intensive versus standard blood pressure control. So to critically appraise this study, I chose to use the RCT appraisal tool from the Center for Evidence-Based Medicine. First step is just looking at internal validity, and overall their patient The patients that they chose, their intervention, comparison, and outcome measures were all quite good. Going into a little bit of detail on that, were their patients was assignment of patients to treatment randomized? The answer is yes. They did do a one-to-one randomization into the intensive versus standard treatment group, and was stratified by clinic site, and they provided their algorithms and formulary for this in their study protocol. Were they similar groups at the start of the trial? And again, the answer is yes. Their table 1 does show that their baseline characteristics were very similar, so they were a good group to compare to each other. Question 2, aside from the allocated treatment, were they treated equally? So they were. All major classes of antihypertensive agents were given free of cost. They all had the same protocol for cognitive testing. So there wasn't any significant or concerning differences in group treatment. Were the patients entered, were they all accounted for, and were the analysis of the group, were they analyzed, sorry, in the group to which they were randomized? The answer is yes. This was an intention to treat trial, and they did have very high rates of completion for cognitive testing, up to 90% for both groups up until the closeout period. They did, however, have quite a bit of attrition at the follow-up, extended follow-up timeframe, but they did mention that. And technically it wasn't part of the trial that they set out to do. Their next question, so were the measures objective, or were the patients and clinicians kept blind? So cognitive testing was done by a certified examiner at each site. These examiners did not determine dementia, MCI, or normal. The expert adjudicators were masked to treatment assignment, and they were actually the ones who themselves decided what the diagnosis may be. They didn't actually see the patients though, so you wonder, like, they're coming in with this packet of information and this functional assessment score, which may be enough, but sometimes seeing a patient can certainly make a difference in what your suspicions are. The other thing I'd say, just as kind of something to mention, is that they didn't really give any information about the patients themselves. I assume they knew their blood pressure targets, but I'm not sure, and they didn't mention if the patients knew what their cognitive test assessment results were, or if they were considered dementia versus MCI. I suspect they had some inclination, but it doesn't specify it doesn't specify in their article. Finally, what were the results? So how large was the treatment effect? So they were presented as a hazard ratio, and it did show significant difference between intensive versus standard treatment for MCI. P-value is fairly good. However, I'm going to point back again to what they mentioned in their statistical analysis section of the paper, where they said that there was no adjustments for the significance threshold for the secondary or other endpoints, and because of the potential for type 1 error, the findings should be considered exploratory, meaning that this may represent some false positive results, and so it's important to keep that in mind when interpreting what the results mean. Finally, will these results help care for my patient? So I think in some cases, maybe yes, in some cases, maybe no. Is the patient so different in this study compared to, or is this patient so different from those in the study that results cannot apply? They had many exclusions, and as I said, and I used my joke before, it was almost, you know, the diagnosis of dementia, diabetes, stroke, we see those patients very frequently, and that makes up a large body of our patient population. This might apply to people who are fairly healthy, coming in for just a simple cognitive complaint, but are otherwise robust. So in those cases, potentially this might be an article or a study that may apply to them. Certainly it's a feasible treatment. It's blood pressure control, although I would say that getting some people down to a systolic of less than 120 may be challenging. And will benefits of treatment outweigh potential harms? So I go back to the original SPRINT adverse effects table, because they didn't take out the SPRINT Mind participants and look at them specifically. They just asked you to go back to the original trial. And it does contain the published data of adverse events experienced by participants. And this is what we already knew from the 2015 paper, that intensive treatment was associated with more adverse events such as hypotension, AKI, hyponatremia, hypokalemia, and orthostasis. But you also have to keep in mind that these participants had lower rates of fatal and non-fatal major cardiovascular events and death from any cause. So it's important to weigh the adverse events with the benefits of intensive blood pressure control. So things to consider, almost done. They didn't demonstrate significance in the primary outcome, and I think this might be for a number of reasons. They did see that their population had a lower incidence of dementia than what they assumed, and this could be due to population chosen versus potentially excluding some of the population that would have eventually gone on to develop probable dementia. Those 1,000 people could have affected their results rather significantly. There was also early termination of the trial, and this may have attenuated any effect seen, as longer follow-up might have showed more impressive results. And finally, blood pressure control in the intervention group reduced over the course of the study, and especially once it was formally concluded, which could have again reduced any significant effects that were seen. Certainly, strength of the study is that it was a good design and they had a big population. The results are encouraging as well because of the mechanistic plausibility. So that is, the pathophysiology certainly makes sense. And because of this, there's still interest in the area. The Alzheimer's Society recently funded an extension of the trial called Sprint Mind 2.0 to continue exploring the links between hypertension control and dementia. So they gave them about $800,000 to try and extend it for another 2 years to see if they could show differences by that point in the two groups. A smaller subset also, there's additional data yet to be published. So about 2,800 participants got very extensive neuropsychological batteries as well. And this will help with contextualizing this study into kind of the other information that's out there about observed domain-specific improvements with blood pressure. So that will be nice to see. And then there's also another cohort of about 600 patients that got MRIs, and they're going to look to see if those results help support the hypothesis that dementia from hypertension is mediated by small vessel ischemic disease. Oh, sorry. And wrapping up. So as I previously mentioned, and I'm kind of repeating myself a little bit here, but some caution should be taken with MCI as a secondary outcome. There was early termination of the trial, and again, as I mentioned before, oh, my presentation wants me to end. It was a healthy population. So finally, what they concluded and what I conclude is that intensive BP control in this population did not show harm to cognition after their follow-up. MCI data suggests signal for benefit in a healthy older adult population, and it does contribute to the evidence that and the hypothesis that hypertension is a modifiable risk factor for cognitive impairment. And I am done.